Hello and Namaste. I'm Dr. Vivek Basukala, consultant arthroscopy and sports surgeon in AKB Center, BNB Hospital, Guarpa, Nepal. Today I'll be discussing about how to read knee MRI by ourselves. So as a surgeon, we need to see MRI for few things. That is for meniscus, to see the integrity of meniscus, to see integrity of four major ligaments, and to see integrity of the cartilage. We also do MRI to confirm our clinical findings, to add on something in our clinical findings. And we also do MRI when we know there is something wrong with knee, but we are not sure with our clinical examination. And we also do MRI to be away from some medical legal conditions. So let us discuss about how ACL tear looks like in MRI. The ACL tear has some direct and indirect signs in MRI. Usually ACL and PCL tear are seen in sagittal films, and direct signs are those when the homogeneous black shadow of ACL is disturbed and there is some intra-substance signal change within the shadow of ACL, or when there is typical tear over the shadow of the ACL in MRI. These are the direct signs. But there are many indirect signs that denotes the ACL injury. One of the most important is ACL-BLUMENSATS line. This is the BLUMENSATS line, that is the roof of the notch, and this is the ACL shadow, homogeneous black shadow that goes from tibia center, almost about enter 1/3 of the tibia to the femur. So this is BLUMENSATS line and this is ACL line. Usually this angle is acute angle towards the femoral side, and this is less than 15 degree. Whenever this angle is more than 15 degree, then this is indirect sign of ACL tear. This happens because the ACL is torn from the femoral side and ACL falls back, thus leading to this angle between more obtuse or angle between acute to the other side. Another important indirect sign is ACL angle. Usually this angle is formed by the tibial plateau line and the ACL shadow line, and usually this will be more than 45 degree. But as described earlier, whenever there is tear of ACL falls down, thus the ACL line may be less than 45 degree. This is also very important indirect signs of ACL tear. Another indirect sign, very important one, is the result of typical pivoting mechanism that leads to ACL tear. Usually the contusions, bony contusions seen over the lateral femoral condyle. This is also an indirect sign. Another indirect sign is PCL line sign. In intact ACL, if we draw the tangential line through the posterior aspect of the PCL, what happens is this line bisects the femoral shaft. But when there is ACL tear, there is abnormal anterior translation of the tibia relative to femur. Thus, the PCL becomes, the shape of PCL is changed and this PCL line goes more posteriorly. Another very important sign is PCL angle sign. If we draw two lines over the two arms of the PCL, it forms an angle, and if this angle is usually more than 107 degree, if this angle is less than 107 degree, then it is also indirect sign of ACL tear. Again, PCL bowing ratio is also another important indirect signs of ACL tear. We draw a line from femoral attachment of PCL to tibial attachment of PCL, and we drop a perpendicular to this line from the most acutely bent part of the PCL. So the PCL bowing ratio is this B to A, and it is usually more than 0.39 degree. It is usually less than 0.39 degree. If this is more than 0.39 degree, that is positive PCL bowing ratio and indirect sign of PCL injury. Another indirect sign is anterior tibial translation and lateral meniscus uncovering. Again, another very important indirect sign is deep lateral femoral sulcus sign, which occurs because of the typical pivoting mechanism while ACL is injured. And if this is more than 1.5 millimeter, this is also an indirect sign. This table shows various indirect signs and their respective sensitivity and specificity for detection of the ACL tear. So let us now discuss about the meniscus. There are various grades of meniscus here. The grade 1, grade 2 and grade 3. Grade 1 is intrasubstance stellate signal change over the substance of meniscus. Grade 2 is linear substance change, intrasubstance change over the meniscus, and grade 3 is if this signal change reaches the intra-articular. This may reach superior, inferior, or both sides. So clinically, grade 3 tear is only considered as through tear because these are the only tears that are seen on arthroscopy, and grade 1 and grade 2 tears are usually intra-substance degeneration. There are various types of tear, as we know, most common being longitudinal tears. Other tears are radial tear, horizontal tear, parodic tear, and flap tear. And there is also another very peculiar type of longitudinal tear, which is called bucket handle tear, in which the medial flap of the torn meniscus is flipped into the knots just as a bucket handle. Blood supply of meniscus is very peculiar. It has centripetal supply, and thus the central part is less vascular and peripheral part is the vascular part. Accordingly, they are classified as red, 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 white, and white, white zone. Again, the meniscus is the fibrocartilage formed by uh, various fibrils, and most important being circumferential collagen fiber, which maintains the hoop stress of the meniscus. This picture shows how meniscus functions. Whenever there is force transmission from the femur, what happens is, because of hoop stress, intact meniscus, there is hoop stress, and the forces are absorbed by the meniscus. So less amount of force is transmitted to tibia, thus the joint is protected. So whenever we talk about the tear of meniscus in MRI, we need to see the type of tear and we need to see location of tear, because these are the very important features which predicts the repairability during surgery. These are schematic diagram of the meniscus and how they looks on MRI. So this is schematic diagram for horizontal tear. So while discussing about the meniscus, all cords are very, very important. The sagittal cord, the coronal cord, and we should not miss to see the narrow cords of the axial section, because these axial section may show the complete radial tear as shown in first picture, and bucket handle tear as in second picture. These axial tears are also very important to look to know the location of the tear. Another very important type of meniscus tear is the bucket handle tear. And in this bucket handle tear, this is a special variety of longitudinal tear. What happens in this condition is uh, this flap of the meniscal tear is flipped, and it goes and lies into the intercondylar notch, thus leading to the locked knee, which can be seen on MRI, axial film MRI, as shown in this picture. So this is the MRI picture showing complete absence of ACL tear, ACL, that is direct sign of ACL, and there we can see in this image. This is the PCL shadow, and underneath it there is something like another PCL. This is called double PCL sign, and this is pathognomonic of medial meniscus bucket handle tear. So there are many other signs besides double PCL sign, and their sensitivity and specificity are mentioned in this diagram. Another important tear is meniscus root tear. These are of 5 types according to Laprat, and most common type being type 2, which is complete radial tear, and which is as good as these meniscal root tears are considered as good as the total meniscectomy. So let us consider this schematic diagram. When there is intact meniscal root, what happens is uh, the forces that is transmitted from femoral shaft is resolved from the meniscus, and thus the forces are decreased, where less force is transmitted from the tibia, thus joint is protected. But when there is tear over the root, that is the complete radial tear, what happens is the force is transmitted from the femur, but as there is complete radial tear, that is root tear, there is no more hoop stress present in that particular meniscus, so meniscus is extruded outside, so more of the force is concentrated over that particular compartment, thus leading to early osteoarthritis and later bony changes. This is the picture, MRI picture, showing extrusion of meniscus, absence of meniscal root shadow, and ghost sign. That is normally seen, meniscus is not seen over here. That is the ghost sign. So these three signs are very typical of meniscal root tears, and whenever we see these tears, we should be very cautious about the presence of possibility of meniscal root tears. Let us discuss something about posterior cruciate ligament. The posterior cruciate ligament is a homogeneous black shadow that goes from posterior aspect of tibia to femur, and it is always thicker shadow than the ACL. Whenever there is ACL tear, this normal PCL shadow is changed and it becomes more of the question mark type. But when there is tear of ACL, there may be direct signs like there is detachment from the femoral side, or there may be indirect signs like there is intrasubstance signals is within the meniscus, or there is detachment from the tibial side. But we must be very cautious to report the integrity of PCL tear in chronic PCL tear, uh, because in chronic conditions, if we do MRI, the clinically absent, clinically non-functioning PCL may be seen as intact PCL, just like this picture. So PCL may be deceiving, chronic PCL tear may be deceiving in MRI. We must be very careful. To diagnose these conditions, the clinical examinations and PCL stress views are very important. These are the various ways how we do PCL stress views, and this is the interpretation. Grade 1 is 0.0 to 7 millimeter of posterior tibial translation. Grade 2 tear means 8 to 11 millimeter of posterior tibial translation. Grade 3 is more than 12 millimeter of posterior tibial translation. Grade 2 grade 2 PCL tear are usually uh, grade 2 posterior tibial translation are usually associated with complete PCL tear, and grade 3 posterior tibial translation are usually PCL tear along with some uh, other ligament tear like medial or lateral corners tears. So let us now discuss something about PLC and PMC. PLC or posterolateral corner were once considered a dark side of knee because their anatomy was not described at that time. But nowadays we know more about this PLC. PLC is composed of three main static stabilizers, that is fibular collateral ligament, popliteofibular ligament, and popliteus tendon. So and medial collateral ligament and posterior medial corners were considered neglected corners because many of these tears were not diagnosed and managed conservatively with long-term morbidity. So medial collateral ligament is the ligament that starts from the medial epicondyle and goes right all the way up to 6 to 8 centimeter below the medial joint line. Another important structure is posterior oblique ligament that starts just below and posteriorly uh, um, from the origin of MCL, femoral origin of MCL, and attaches very near to the joint line. This posteromedial corner is also known as semi-membranous corner because most of the posteromedial structures are formed by expansion of semi-membranous tendon attachment. So MCL and posterior oblique ligament are the structures which are most important in the medial side, and these are the two ligaments that we reconstruct clinically as it's shown in this picture. So PLC and PMC injuries are rarely occurred alone. They are usually part of knee dislocation. Usually they are missed, and if missed, they have grave consequences. So how the normal MCL and PLC looks like in MRI? This is the picture that shows some black homogeneous shadow that goes from right over the femoral condyle to 6 to 8 centimeter below the joint line. This is the MCL, and it is very well adherent to tibial and femoral surface. But this is another structure in lateral side. Um, in this coronal film, we can make out some lateral projection of the human face, and from this mouth, you can see some structure going out. This is the popliteal hiatus, and this is the popliteus tendon. And from this forehead to fibular head, there is a homogeneous structure which is the LCL. This is the picture that shows various types of MCL and PLC injury. This is the wavy structure over the medial side. That is the this is this denotes the MCL tear. Again, this is another picture that shows the waviness of the MCL over the femoral side, even at the tibial side. So this is in mid substance tear with waviness and superiorly and inferiorly, and there is some tear over the femoral at tibial fibular attachment of the PLC. This is normal picture that shows normal LCL with normal popliteus and normal MCL, and this is picture showing sprained MCL. That is, there is some waviness, there is some change, signal change over the MCL shadow, mainly the deep MCL, and there is some signal change over the femoral attachment of LCL, along with some signal change within the popliteus tendon. These are again the images that shows various degree of ligamentous tear within the knee, and again this image shows the tear of PLC from femoral attachment side and popliteus tendon tear and sprain of the We should not only focus on ligaments and meniscus. We have to see for various cartilaginous lesion as well. And most of the most common traumatic condition is osteochondral fracture. Usually, osteochondral fracture occurs from trochlea, femoral trochlea, or the from the patellar facet. So this is the patella, and this is the cartilaginous facet of the patella. This is the medial facet, and this is the lateral facet has been fractured over here, and this fractured osteochondral fragment is floating over the hemarthrosis thus formed. So this axial image is very important. We have to trace all the cartilaginous structure, cartilage from the femoral trochlea and posterior aspect of the patella before diagnosing, before ruling out all type of injuries in the acutely injured knee. So I would like to conclude that whatever progress we make in technology, these MRI and all other investigations only aid in our clinical examination. So first and foremost, we must rely on our history and good clinical examination, and MRI and all other investigation will only add will act as add-on to our clinical examination and history.